It's just an enormous pleasure, just wonderful thing to be able to welcome Dr. Cassell, Eric Cassell, to the Eastside Institute, and to join me in a conversation about what philosophy's got to do with our health, or philosophizing. And before I introduce Dr. Cassell, I would like to just say what I think, why I think it's important. In this national dialogue on healthcare, that is kind of bombards us every day in the news, one of the things I think that's very striking is that it is almost entirely focused on healthcare delivery and the economics of healthcare. And it seems like extraordinarily important to think that philosophy has to do with our core practice, our methods, our approach to health and healing, and how we value human life and how we see the humanness in a person. And my concern, and I think Dr. Cassell shares that concern, if we don't address some of these core issues of medicine, even though we may achieve a slightly better distribution of healthcare, I don't think we've done very much to really respond to our ailing healthcare system. So I wanted to just introduce Dr. Cassell from the vantage point of his journey to philosophy. Dr. Cassell, many of you know him here. He's a renowned teacher, clinician, author of numerous publications on the theory and practice of medicine. He has been on the faculties of, I can't even count the number of medical schools that he continues to maintain his faculty affiliation with, but most notably New York University, Mount Sinai, Cornell Medical School, and now currently, although retired from clinical practice, is on the faculty at McGill University and is helping them to develop a new curriculum that he will speak to, but that focuses on the person. I thought it was interesting, in 1971, Dr. Cassell describes in his biography that it was a generous act of fate that placed him on the task force on dying at the Hastings Center. And this experience changed his life, broadened his horizon, and pushed him to study, read, and write, and give substance to what he describes as a genetic predisposition to philosophy. And he began to wonder whether a doctor could actually treat patients in a successfully useful and special way because they were dying. Since the start of that journey, Dr. Cassell has written about, lectured on, and has been a leader in exploring the moral problems in medicine, the care of the dying, and the nature of suffering. He is author of numerous books. I'm not going to go through all the titles, but one that I particularly like, The Nature of Suffering, which now is in its third edition. Yes. And he is currently working on a new book, The Nature of Healing, which is in the works. Since many of the people here know Dr. Cassell and perhaps don't know me, I am not quite a retired clinician, but semi-retired, I guess is how I would put that. I've always been very interested in patients, the doctor-patient relationship, but had very little working knowledge of philosophy. What I did gain, I gained in a mass survey course of 2,000 other students at University of California at Berkeley. And I must say that I didn't bring a lot of philosophical interest or questions to my practice of medicine. Sometime, but I always was what I called a patient-centered doctor, I guess. And I was hired as a young faculty member at the University of California at San Francisco, my alma mater, after I graduated, to develop and run one of their first doctor-patient courses. This was in the late 60s. It was probably under the influence of the counterculture and the women's movement and the Black Power movement that this became a part of the curriculum at all. So my journey, I guess, or my performance of philosophy began over 20 years ago when, in the course of one of rather prolonged dialogues that I used to have with Fred Newman, who is a philosopher. He is the founder of the East Side Institute in this approach. And we would have discussions about health. And one day I was telling him about this doctor-patient communication course I was teaching at a hospital where I was working, and I was very excited about it. And he said, Susan, he says, how can you possibly methodologically separate the doctor-patient and the doctor-patient conversation into a special course when that's what medicine is? That it just was absurd and didn't make sense. And I started thinking, and I said, well, you know, there's medical science. And then he said, well, what is medical science apart from what goes on between doctor and patient? And I said, well, there's really diabetes. I always used to, there's really a thing called diabetes. And he said, maybe you should question that diabetes is simply a name that you and the patient use to describe something that's going on, an activity, but that's not what medicine is. And so that was the start of my journey into a more philosophical inquiry into medicine. So I'm really thrilled to have Dr. Cassell here for this conversation. He's been an inspiration to many of us who've come up in the next generation who've had this interest, and this is a growing field in medicine, as many of you know. And I think that for us, he's been our teacher and our mentor and an inspiration to this continuous inquiry into the nature of medicine. So, thank you. Dr. Cassell is also a member. Yes, I know, he's getting very impatient with it. He's also a member of the Institute of Medicine, which I hope people read in the New York Times today, came out with a statement that said doctors should not accept pens, sticky pads, money, or trips from the pharmaceutical companies. That it was not immoral, but it does somewhat bias us. So, I congratulate your fellow.
I never did it.
I just want to congratulate you and your fellow Institute of Medicine colleagues for coming up with that. So I wrote some questions. I'm going to be asking Dr. Cassell to discuss with us. Broadly speaking, I said it was about science and scientific methodology as it informs and shapes our practice of medicine. And one of the things is, within the field of primary care medicine, there's just a lot of dialogue and talk. If you read the medical journals, if you go to a conference, they all say, primary care medicine needs to be on a scientific footing, with evidence-based medicine, which we've all heard that term, algorithms, treatment protocols, as roadmaps for what is the standard of practice. And I think that it's very good to have standards of practice in many ways. I think everybody should know what the standard of practice is. It should be much more democratized. But my concern is that these roadmaps are based on findings on what I would consider to be aggregates of patients, the P number, the generalization about patients, and are being used as a standard of care for all patients. So I wanted to know and ask you how you see the individual with their particular needs and wants fitting into this system of protocol-driven medicine, I call it. And how do we give the achievements of science and scientific technology to our patients as the unique individuals they are?
And you know how it goes? Somebody asks you a question and you answer the question you want to answer.
And you'll answer the question you want to answer.
Well, I want to start off by saying I think that medical practice at the present time is in bad shape, and most people have that feeling. They have trouble, getting appointments, and they're not satisfied with this or that. And it's going to be in bad condition for a number of years to come. But and the effort to extend it to everybody is long overdue. So, but you have to understand that medicine has a history, and it's not one single thing. It's not just what happens between doctor and patient. And so, when we look at it, we have to see, well, the medicine that we all know is about 200 years old. It's a medicine of diseases. diseases were really invented, of medicine, the way we talk about them, things like diabetes or congestive heart failure or whatever, were really invented only around the turn of the 18th to 19th century, primarily in Paris, I might say. They were invented because people did autopsies on sick persons and then saw what was the matter that went along with what they complained about, and began to put medicine on a solid basis of knowledge, of anatomical knowledge, and so forth. And that laid the basis for modern medicine. That correlation between what was wrong in the body and what people complained about. And not only did it do that, it produced a language that people could understand all over the world. So not only was it good, but it was also systematic, so that people could understand it. And that allowed science to enter medicine in a way it had never done before. So that by the time the 20th century came along, there was a scientific basis for medical practice. Now, why weren't emotional things a part of that? After all, people had emotions even in Paris, and people still have emotions in Paris. And why wasn't it? Well, because it wasn't invented. The emotional life that we all live was not invented in those days. And why weren't social things part of it? Why wasn't poverty part of it? The medicine they practiced and all that? Because it wasn't invented. Were there no poor people? Of course, Paris was filled with poor people then, and probably still. But they hadn't come in any systematic way. So it was a disease system, and it was a scientific one. And when it came into the 20th century, it came in that way. And when you go to a doctor, that's still the way you do it. If you're sick, you think you have a disease. And you're used to somebody saying, well, there's nothing wrong, meaning you don't have a disease, so you really aren't sick. Well, that's the past. And the trouble is, moving from that path to the contemporary one, where we really believe emotional things are part of it, and psychological things, and social issues are all part of medicine. That motion must be like having quadruplets or something, because that birth from that medicine of the past to the medicine that I expect is coming seems to be a very difficult birth. And one of the reasons that was believed to be the reason it wasn't going to happen was doctors did things on matters of their own opinion. And so if I think you have whatever disease it is, well, let's pick one. If I think that you have pneumonia, I know, I'm taking care of you, I know you for a long time, and I think you have pneumonia, then you have pneumonia, and I have ways of doing that. Well, that seemed to be a matter of opinion, and we ought to be able to lay down criteria that anybody could see and apply, and then we would have a routine, a knowledge-based medicine. But actually, it's a bit of a red herring, because by the time these things came along, everybody already was rooted in evidence. You expected your physician or nurse practitioner or clinician or whatever, whoever, knows something, and that they know this systematic knowledge. And the trouble is, as Susan says, that how do you make this kind of general knowledge apply to an individual? Since really everybody's different. I mean, everybody is different. There's a picture. There was a picture. Where else? Los Angeles Museum of Erotic Art or something like that had a picture of 100 people standing there nude, naked and nude are different, standing there naked. And there are 100 people, I don't know how they all got to do that, but there they are, and you know what's the most striking thing? Boy, are they different. Everybody is different. And that would be merely amusing, something you don't know anyway. But those differences have an impact on the way you're sick. Two people with the same disease 2 people with diabetes, 2 people with pneumonia, 2 people with congestive heart failure will have a different illness. It'll behave differently, they'll have different symptoms, they'll present differently to their doctor, and this is what Susan was referring to. And they are different. So that if you apply a set of rules generated from a large number, so they're statistically good, they won't fit individuals very well. And what is the instrument that we expect to move from that general knowledge to the knowledge about you? That instrument is your clinician, the person who takes care of you. That's the instrument that makes the universal or the general apply to a specific thing. The trouble with that is, and I don't think there's a soul in the world who would argue about that, it's a rather benign statement. The trouble is, we don't train anybody how to do that. You see, when we get trained, we see lots of things like, if you took all the people that you know and you said, we're going to see what the comparison is between height and weight. You know, if you take 100 people of the same height, they're not all going to weigh the same. Or you take 100 people of the same weight, they're not all going to be the same. So you would make a graph with a bunch of dots. This weight goes with this height and so forth. Right? Scientists, and statistics is one of the major step forwards in medicine, can draw a line through that bunch of dots, and that shows you the general relationship between height and weight. Mostly as people get taller, they get heavier. That's, I don't mean to trivialize it, but that's science. That line represents science. You could do the same thing for all kinds of things. The dots represent clinical medicine. Everybody is different. Now, doctors are trained on the line and not on the dots. As a matter of fact, that's what everybody's trained on, except artists, probably. Psychotherapists, initially are trained on the line just like everybody else, and then they gradually learn that set of ideas they have about emotional problems doesn't fit everybody. So we don't train anybody how to go from those dots to individual, that line to individual. And because ultimately you have to trust people that they've learned it and that they can be trusted to apply that general knowledge to individuals. And that brings us to this century, the beginning of this century. The people who make these rules don't trust doctors. We educate them, you see, but the minute they step out of a medical school, we don't like them anymore. We can tell you all the things that are wrong with doctors, and I always think, that's amusing, we train them. And so what we don't like about them is, of course, that they have their own opinions, and just like everybody else. And instead of training people to have opinions so that you know how to make judgments, we don't do that. So we have these guidelines, and we have doctors who take care of people who learn very quickly that everybody's different, and who learn very quickly that you have to figure out how to apply what you know about diabetes or back pain or urinary tract infections or whatever it is. They have to learn it on their own. Well, that's a very bad way to learn things because it takes so long. See, when I stopped, I was practicing for almost 40 years, and I was better then than I was 10 years earlier, and that means that somebody didn't get treated as well 10 years earlier as they did after, and of course it follows from that if I kept it up, then I got better treatment still.
Well, are you? Because I know if you read the literature, as it were, about this whole issue, they will say that you're just using intuition, and intuition is not scientific and therefore should not be encouraged. And I mean, I think intuition, we use language very particularly in medicine, and I think that's, an issue that all of these things could, even evidence, like what really counts for evidence, we're saying, is the patient's accounting often doesn't account for anything, evidence. What really counts for evidence is what you can abstract.
What you can measure.
Yeah, and what you can measure. So I was wondering if you're saying, is that what doctors develop, is intuition, or
they develop judgment. They develop judgment. Intuition gets them more information. But they still have to act on that. And that, even if their intuition, I mean, doctors have been around a long time. They know when something's wrong. So what happens is that they see somebody and they hear the story and then they don't find anything, but they know there's something wrong. So they keep looking until they find it. And how do they know? Well, we call that intuition. Intuition, lots of people think, is it's not second-class knowledge, it's first-class knowledge. That's what John Locke thought. And but the other thing is, how do you take that information and apply it? And that's judgment. And nobody can teach judgment, because judgment is, by definition, the application of the universal to an individual. So since it's about an individual, we can't teach how to do that. But on the other hand, you can teach people how to go about it, but we don't teach judgment. We expect that they'll learn it, doctors will learn it by themselves, but we don't teach it. So what I'm saying is that it isn't intuition. I mean, given facts that you get from a machine analyzing blood, you still have to make some judgment about whether how about maybe you want to disregard those. Maybe you think they're not correct. Maybe you have a report in front of you and it says this is Eric Cassell's blood thing, and then that's terrible. Then I think, well, wait a minute, that doesn't make sense. We had one last week and it was perfectly normal. So how could it be so? Maybe it's not my blood. So we don't right away, toss them in the grave. We'll get another set of blood and look again. What tells you that? Judgment. No, you don't think that's an odd judgment. It makes perfect sense. It's when it gets closer than that that it begins to get hard. I used to say that the best decision is a decision you never make. It's only when you make a decision that you get into trouble. So how can you never make a decision? Oh, when the thing speaks for itself. When you know so much about the situation that it isn't really a decision, it's self-evident. Well, of course, that doesn't always work, does it? And in the issues, and this is the point of this, is in the issue between that, you have uncertainty. You don't like uncertainty. And nobody likes uncertainty. We used to train doctors for uncertainty. There was a famous medical sociologist named Renee Fox, who once wrote a famous chapter called Training for Uncertainty. But we don't train people for uncertainty. How to live with uncertainty, how to resolve it, how to go around it, do all those things. We don't do that. So we're stuck with untrained decision makers who have to get it by themselves, and that's not a reliable way to do it.
Well, one of the things I was thinking about, I just read this another journal article on how doctors use science. I think it was an editorial, and like 80, particularly I think it was in primary care, like 87% of the physicians they were surveying in this thing with a clinical problem didn't follow clinical guidelines or evidence-based medicine. So it seems to me that's one of the issues, is there's a tremendous gap between the way we're taught as medical people, and I want to just, I meant to say this at the beginning, but I'm going to say it now, is when I talk about doctor-patient, I really, it's a euphemism for any healer, or a nurse, doctor, chiropractor.
That's why I switched to clinician.
Yeah, clinician. And so it seems to me an enormous gap between how clinicians are told they should do things, or trained, or what they're told is right, and what we do. And that seems to me something that would be for me, what I do often is within the nexus of that doctor-patient relationship, or what's going on in the room, as it were, and what the patient is telling you they want to do with this. So it seems to me that there is a gap, and I remember Fred Newman, who you had a conversation with 10 years ago, was talking about that there seems to be a very big blank between what we do and what they say we should do.
Well, it is interesting that people don't all brush their teeth twice a day, and they don't floss the way they should, and all that sort of stuff. And it is also, but that's trivial because that's their business. It's their mouth and their teeth, and what the hell? They don't want to do that. That's their business, right? But if I'm the physician and I don't do what was now accepted practice for good reason, and you've had a heart attack and I don't give you a drug, aspirin or something, an equivalent thing after that, that's a mistake. I should do that because it's clear that that's better for me. Why don't people? Why in the face of it? It's not lack of knowledge, believe me, because it's everywhere, what you should do. Why don't people do what they're supposed to do? Now, there's no answer to that. I do not know the answer to that. But the remarkable thing is, lots of people don't do what they're supposed to do. And some of those people are responsible for your well-being. One of them being you, of course. And
well, I get a letter from HIP, and it says to me, how come you haven't got Mr. X on Lipitor? Because his cholesterol is high. And Mr. X is saying to me, I don't want to take these drugs. I'm scared. They'll hurt my liver. I'd rather do it other ways. I don't want to do it. And then I get a bad report card.
Well, but then I expect that you've taken on the problem of Mr. X not doing anything about his cholesterol as a mission, and that you keep on the poor bastard until he finally gives up and takes the medication. That's what I would do anyway. And but since you can't call him every day, and you can't track him down and beat him up because that's not allowed. So you're forced to do it in other ways, right? And talk about it. And a lot of people don't like to do that. So you get a bad report card when Mr. X doesn't take his Lipitor anyway. But the fact is, we understand that he doesn't want to take it because he thinks drugs are worse than whatever. Or he thinks that he couldn't have that trouble because his father didn't have it. Or he could have it because his father had it, but look at how much more exercise he does than his father. So, and his father was a son of a bitch anyway, and consequently that Lipitor doesn't apply to him.
You do a pretty good imitation, I'm just saying.
I've heard a couple of that. And then there's the other person who takes 2 Lipitor because if one is good, 2 is probably better. All that tells you he doesn't pay for his own Lipitor. But anyway, the thing is, those things happen, don't they? We would like very much for people to follow the rules and do what they're supposed to do. And generally and for the most part, I think people do. But not everybody. And but that's not my problem with it. To me, it's an important issue. My issue is, this is I'm sure not true of you, is that when somebody says, I don't want to take that Lipitor, that's not the time to start talking. That's the time to start listening. Because people, when you don't change. If somebody doesn't want to take it and all the evidence says take it, it's not because they're stupid. Although that's what interns say. He's just stupid. He didn't take his medication. I would think, wait, sonny. There's a reason. Now, it may not be a reasonable reason, but there's a reason. I mean, by my life. But if you listen long enough, you're going to hear it. It may take a lot of questions, but you're going to hear it. You will never change anybody's mind until you know what their mind is. And you will never change their mind by telling them. It didn't work for me when I was a child. It didn't work for me as a father. And it doesn't work for doctors. People, you're asking somebody to do something that they don't approve of just because you told them. It's a terrible reason.
Well, to me, though, and I just want to talk more about it, because it seems to me that Mr. X is, to me, very important in our research in terms of how we go about doing things. You know, what's important here. And it does seem to me that one of the things I have an obligation to do is to share my science with Mr. X, and my other obligation is to listen to him and to create something together that has something to do with would promote his health that isn't persuading. Because when we talk about persuading, I find that to be just a activity that can be very coercive. I think, I mean, the number of people that I see in my practice who came to me when hormone replacement therapy was still in vogue, said, I'm changing doctors because I don't want to take it. And my doctor keeps, quote, persuading me. So it does seem to me that somewhere in this discussion of what we do as clinicians, it seems that we need to be able to sort of come to something. Is it science? But it's some new way of thinking about doing this other than the protocol, because that's where I find the tyranny of the protocol.
The protocol tells you ought to do it.
Yeah.
But on the other hand, if you respect persons, and you really respect them, and you told them why, and they don't do it, you'll tell them the next time. Either they have what everybody always talks about, autonomy, or they don't. People have a right to make a mistake, just like they have a right to do the right thing. You should do your job, but if it doesn't work out, it doesn't work out. Now, but that's not the way you're being treated. The thing that sends you a message that Mr. X's cholesterol is up, and you get a bad report card
from HIP
or wherever the hell, you're getting a bad report card because you're not meeting the criteria that of what percent of your patients to get it right. Well, now, are they people or aren't they? Are they persons or aren't they? You can't have it both ways. You want them to be treated as individuals, and when they act as individuals and you don't agree with it, then there's something wrong with them. Now, I happen to think that my way of doing it is extremely persuasive. But and I do want you to do what I think is the right thing to do. But on the other hand, people have a right to be wrong. They have a right to die early. They have a right to die late. They have a right to live their lives. And their doctor is a helper. That's all. Is a helper, not the boss. Now, there are times when you need a boss. If you're lying in an intensive care unit and you don't want to cough, and if you don't cough and get up that stuff after the operation, that's bad for you. I'm going to yell until you goddamn well cough. You're going to cough. Now, can you treat any other adult that way? No. Can any other person treat another adult that way? No. Clinicians can. But that is an obligation, not just. In other words, if you can do that, then you have an obligation to make sure that you do it at the right time and for the right reason, and that depends on that person in that bed. And that is where it gets more interesting and goes past the guidelines and so forth. It's those things. People who watch doing something that's going to do them real damage, and you know it. It's painful to watch that, isn't it? And that does not give you the right to boss them around.
Well, you've written a lot about this personhood.
Yeah.
This sort of, it's a concept. It's a key concept in your understanding about medicine and the activity of medicine. And I think we both agree it's not scientific or a scientific concept. And I was wondering if you could say more about that, in particular, just in the relationship to this things we've been talking about.
Well, love isn't a scientific concept either. And neither is taste. And neither is everything else that you really think is important. They're all in the value, in the line of values. Do they then not exist? So the fact that something isn't a scientific concept simply means that for that concept, a person, or love, or taste, you apply other standards besides scientific ones. Science is good for what science is good for. If you can't measure it, you have a tough time making scientific decisions about it. And persons aren't measurable in those ways. In the thing. Now, the thing about person, watch out because this is my thing. But, you know, it's a disease-centered medicine, as I explained, starting back 200 years, and it can go all the way up. And it's a disease-centered medicine all the way up until the Second World War. Not everywhere, because even in the 20s, there were people who were saying we have to pay more attention to the particular person. But after the Second World War, patients became persons. And you think that, weren't they persons before? Oh no. They were patients. Well, what's the difference? Oh, persons have agency. They're considered able to do things for themselves. Not patients. Patients weren't considered to have agency. Now, I had this funny thing. I took care of a man who was the president of one of the big movie companies, and he had pneumonia. And this must have been in maybe 1960 something. Anyway, I went into the hospital, and his wife and I went to the room, and I explained what was going to happen. And then his wife and I went out in the hallway, and we had the conversation. Now that was, in those days, that was the real conversation. See? You didn't necessarily tell him the truth. I did actually then, but people didn't necessarily. But with the wife and I, we had the real conversation. Try that today. Or what's changed? Well, what's changed is patients have become persons. We don't treat persons that way. Well, when did that happen? Well, in 1954, when I was getting out of medical school, people were talking about treat the patient as a person. That literally means treat the patient as if a patient was a person. And in fact, funny as it is, that's what it meant. But then what else happened from 1954 until, let's say, 1970? Who else became persons? Women in public. They've always been persons in private, but women in public. The civil rights movement. The women's movement. Coming all the way up to the gay movement. The rights of persons with disabilities, which is the most recent one. All these are people who have achieved personhood in our society. Now, it's a strange thing, but that means that people are treated differently. The society treats them differently. Well, patients were like that too. So, when we see this particular administration, which is really different, thank God, and we also see it's in a different world. So the medicine that we're talking about is in a different world. So when I say we want a person-centered medicine, it's because we're now dealing with somebody different than the persons who were sick up until, in Paris, in that Paris hospital, when a person died, they did autopsies. And if it was inconvenient to do it somewhere else, they did it in the patient's bed, which must have been a bit of a shock to the guy in the next bed. Which means they didn't give a shit about him. Right? Well, we don't do things like that anymore. And not because we are nicer, just like doctors don't lie to people the way we used to when I was first interacted. is because then we were liars and now we're not? No. The world changed. We weren't lying, we were doing what we thought was best for that person. And lying was part of it. Now, we don't believe that. But there are times when I promise you, you don't really want to know the whole truth. Not maybe yet today, how about tomorrow? So, the world has changed. Now, the thing that's interesting is, about persons and sickness is, who you are as a person, the particular you, makes a difference in what kind of illness you have, in when it comes to attention. I mean, supposing you have diabetes, but you're a runner, and somebody else is slothful. The slothful person with the same predisposition to diabetes, who eats the same way as you do, although that's probably unlikely too, he's the same, is going to have their diabetes show up earlier than you, the runner. Is that because you're better or whatever? No, it's because who you are changed how diabetes behaves. And the slothful person changed. So the way the disease presents itself, supposing you come in at the first sign of illness, you have a sticky toilet seat, and you say, my toilet seat was never sticky before, I wonder what's making my toilet seat, and I say, I wonder if you have sugar in your urine. That makes a sticky toilet seat. That's a piece of information you may not know. Anyway,
Watch out.
you'll come in right away, and that person over there, your patient who doesn't want to take his Lipitor, doesn't like doctors, hypothetically, and doesn't want to go to the doctor, doesn't trust doctors and so forth. That person comes in later. So the first one's going to alter, who the person is alters how the disease presents itself. It's going to alter how when the diagnosis is made. Suppose you don't like x-rays, and you don't want to, whatever. Then you don't get it, and somebody else does. That's you affecting your disease. Mostly when you say people affect their own diseases, people run right up to some unconscious thing that the 5-year-old controls, and that's what's doing it. But it isn't that. It's in all these everyday ways. So you alter when your disease shows, how it's diagnosed, and you alter the treatment, like your man with Lipitor. His hypercholesterolemia is different than mine. I couldn't be happier to take that. Because it works. Well, I care. And I have insurance, and so, So anyway, and then what happens to him and me and you and whatever is going to be different. And how it all ends up is going to be different. So the person has an effect on the disease. And not only that, the disease has an effect on the person, right? And when something affects you, that changes the way you behave, so you change it, which changes you, which changes it, and so forth. Well, that's a lot more interesting than diabetes is a disease of sugar metabolism, which probably isn't what it is. It's probably a disease of fat metabolism. But in any case, so that's much more interesting. If you look at it just as diseases, then it's all that stuff that we're talking about. But if you look at it as persons, then you have to know as much about that person as you know about the disease. Well, does anybody know a lot about persons? Not usually. By the time doctors are finished, they've learned a fair amount about persons. Unfortunately, they needed that at the beginning. Psychotherapists learn about persons, husbands and wives learn about a particular person, and then when they get a divorce, what do they say? I thought I knew you. So person-centered medicine is a medicine that's centered on the fact that disease isn't the only important thing. It's this interaction between. But it goes even beyond that, because there's another thing about persons. Persons are of a piece. Whatever happens to one part of a person happens to the whole person. If you stub your toe, do you think it's just your toe? No, you're limping around. That changes the way your hips work. That changes your attitude. I don't know. Beat it to that. The fact is anything that happens to one part of a person happens to the all. And anything that happens to the whole person happens to every part. Well, that's interesting. If that's the case, and I think it is, and I think it's not hard to prove it, if that's the case, let's supposing your illness is really spiritual in origin. Let's suppose, because spirituality isn't just religion, it's also your connection to other people, or your connection to something larger like medicine. And supposing you have a spiritual affliction. Well, if what I said is true, if you have a spiritual affliction, something's going to happen to your body because that's a part of you too. Right? And since the only tools we have for finding out what's wrong are tools that measure the body, we'll think it's a body disease because that's the only thing we can measure. And so that's where we'll direct our attention. And we'll be helped along by all the guidelines and everything, but don't miss the point. Because we should be looking at the person much wider. Now, to me, that's person-centered medicine at the minimum. But when you read descriptions of it nowadays, see, that turned out to be very difficult. So that idea got abandoned. It's one of those things. It's that streetlight problem, you know, the guy looking under the streetlight for his lost, whatever it is. And why is he looking there? Because there's more light there, even though he lost it over there. So, the interesting thing is, if you read descriptions of person-centered medicine now, in 2009, 8, 7, 6, it sounds like politeness.
Yes. Be nice to the patient.
Yeah, well, we want to be nice. We want to pay attention to your wants, needs, desires, and values. It's very accommodating. It sounds very benevolent and humane. But that isn't person-centered medicine. Missed it again.
Right.
Why? Because if you're going to do person-centered medicine, don't you think you have to learn something about persons? I know a lot of medical schools. Two come to mind at the moment. One is the University of Rochester, which is a really good school that really thinks it's person-centered. But they don't have a course about persons. And the other example I always use. Anyway, and not only that, they also think that it works like this. There are two kinds of knowledge. There's science, that's what you really been saying, right?
Well,
And I'm picking on you, and I'm allowed to go. But there are two kinds of knowledge. There's science, and there's all that humane shit. And, the soft stuff. So, of course, that's how you run your life, but leaving that out. There's science and that's soft stuff. And the way it should work is, according to what these schools teach, is there are two lines of knowledge. They come together at the patient's bedside. And there I'm quoting, weave back and forth between our scientific knowledge of their disease and our knowledge of them as persons. Where did they ever get something as dumb as that from very smart people? Well, I mean, my son's an architect and they build buildings, and I'm sure that they build a building and then they put the aesthetics in later or at the end. They don't do that. This has to be there from the beginning, right? It's woven together inside that physician.
well, I completely agree with you that medicine's dualism is
wrong.
at the beginning is wrong. Yeah, I mean, I think many of the ills, because having taught, doctor-patient for a long time, my experience is, when push comes to shove, all that other stuff, that humanistic stuff, we don't have time to do that. And that was literally how people talk about it. It's well and good, Dr. Massad, but we really don't have time. And I think that's the consequence of this dualistic way of thinking about it. I would love to talk to you all evening, but I really promised people who came to open it up for questions. And so
Good.
would love to have people in the audience join our conversation. And questions.
Yes.
David.
What about the placebo effect? How do you decide if something is a placebo or is not?
Well, the placebo effect for everybody is if you give somebody, here's the real medicine and here is something that looks just like it, and if you give the placebo, that fake but otherwise identical looking thing, a number of persons will respond as though they got the real McCoy and have some, if they will get better, or they'll have some improvement. Well, what we often say is, look at the amazing thing of the impact of the mind on the body. Right? Because that looks like that must be, the mind made them better. Well, wait a second. If the mind made them better, was it sitting over there and then it gave the body a big thing? Or give it a hit and make it better? It could. The mind is part of it. So the placebo effect shows you that in fact people as a whole respond to not just chemicals in their blood, because when you give somebody a placebo, it doesn't drop out of thin air into the mouth or into the veins. It comes from a person to another person, and often a trusted person, like your physician. And so we would say, well, maybe it isn't just the mind, maybe it's the effect of the relationship. Oh, well, that's the mind, isn't it? No, well, why do we call it a relationship? If it's the mind, why don't we call it the mind? It's a relationship. You don't think relationships have an impact on you? And since we're social creatures, there is no person without others. Even when they're alone, others up in there somewhere. So the placebo then has its impact on the person, in part because of the relationship that went around it, in part because of the setting. Most people who get placebos are not on a desert island and the thing goes boom into their mouth. They're in a setting with the expectation of betterness. Except for some people who have an expectation of worsening. And they have a negative placebo reaction. It makes them worse. But again, there's the setting, the structure of the setting. Now, when I was a medical student, I read we used to see a lot of people with asthma in emergency rooms, acute asthma. And I read this paper that showed that people who had an acute asthma attack, they would drop their blood sugar. I thought, I'm going to give them intravenous sugar, and they'll get better. So I did, and they did. Isn't that wonderful? But then I thought after a while, what if I gave them intravenous saline, salt water? I gave them that and they got better too. So wasn't that just as good as the real medicine? No. Because later in the night, in the middle of the night usually, the people who got the placebo were back in again with asthma. And the people who got the real stuff weren't back in again with asthma. So yes, there's a placebo effect, whatever it is. And I'm not saying what it is because I don't know. But the real McCoy can help or hurt more potently. So yes, all these things have an impact on the person, but then we would suppose they did, because look at the stupid things people do out of relationships, because of relationships, and the stupid thing they do because they have an idea in their head, and all of that. And all of those are just like the idea that goes with that pill, or the idea that goes with
June and Maggie and Jessica.
Dr. Cassell, it's I'm very glad to have the opportunity to hear you, and I hope many, many people hear you, because you have some really important things to say. Susan is my internist and a dear friend, and I hope as well that many, many people hear her, because she also has a lot of good stuff to say. I wanted to get your thoughts on something that's been something personal and that has been going on with me and having to do with medicine. About six months or so ago, I got diagnosed with breast cancer. And fortunately, it did not spread, and I had a lumpectomy, and I moved along pretty easily on a track, because that we know how to deal with that. You know, fortunately, I have many friends and loved ones, and Susan as my doctor and friend, to do this very socially and not by myself, and kind of work it through as we did it. I also have a pacemaker. When we started after the surgery and after a certain healing process, it was decided that I needed, well, we did decide that I needed radiation. And the doctor said there was no problem with the pacemaker. There's absolutely going to be no problem with the fact that I have a pacemaker and I was going to have the radiation. And we started the treatment. And when we started the treatment, my pacemaker, I mean, as soon as we started the treatment, my pacemaker went from like 70 beats a minute, 60 beats a minute to 160. It was like wild. And I would tell my cardiologist and the radiation oncologist, this is my heart, my pacemaker is beating wildly. And the response I got from very caring, very fine doctors, it's impossible. They never heard of this before. It's impossible. It's just not happening. It couldn't be happening because it's never been heard of before.
Well, somebody had to be wrong, you or them. So.
Well, I mean, one is, I think that because I had all the support that I had, I pushed and persevered and didn't kind of like shrivel up and think, well, maybe it's in my head. I mean, one of the doctors was saying that, well, you must be very nervous. Well, I was nervous because my heart was beating, but my heart doesn't beat because of my nervousness. I have a pacemaker. And finally, and you know, so it was like kind of they knew. So what they knew. So they couldn't, what I was experiencing wasn't brought into this. And two, it was like, as far as being related to as a person, and again, these are good people. I mean, I was either like becoming a pain in the ass, or I was like a hysterical woman, or I was like whatever.
But notice that you thought that too. At times, not only did they think it was stupid, but
I thought I'm making too many waves.
Exactly.
What, you know, maybe I should just go along with this, but I didn't. And finally, they tested it and
guess
saw
what?
that. And there it was, and they did something.
But the thing about that, bad medicine is bad medicine. So there's no other way to put it. When something is done wrong, it's wrong. That's all. Is there an excuse for wrong? Well, the most common excuse is that happens all the time. Like, that's a sort of statistical excuse for wrong. But what's really wrong is nobody listened to you. Because that's right. Now, you see, so the thing about it, aside from the distress it caused you, because this didn't take place over 10 minutes, and also it shakes your confidence about your care in the future and all those things, and then all their friends the same thing. But it has to do with what we spoke about in the beginning. Why don't people do what they're supposed to do about, not you doctors, about giving a patient this medicine they're supposed to give? Their solution is to be either open and listening and able to change. They're now seeing something they never saw before. Either it isn't there, which means you're wrong, or it is, and if it is, they have to change. You know, when you hear something new, that isn't just a thought. You have to change everything. A new idea changes every other idea. And that's why people change heart. Now, what's the excuse for what? There's no excuse for that. That's just bad medicine. And everybody at the end was apologetic if he was still going to see them, but that didn't help you from before.
They weren't even apologetic.
Yeah,
It was like, well, we didn't. How could we possibly know this because we didn't test it?
We'd
Now
never
that we
seen it
tested,
before.
now we know it.
Okay.
So it wasn't an apology.
Other than bad medicine, what do they used to say? Bad cases make bad law, right? This isn't a bad case. It's a perfectly good case to listen. Why didn't you listen to it? Why didn't you could have asked what actually happened? Would have taken 3 or 4 more questions. But why? Because this is not an excuse for it. I want you to know that. Why? Because if it turns out to be what you said, then what they know is inadequate.
Yes.
Well, when what you know is inadequate, do you think that what you know is inadequate or that you're inadequate? Most people don't like to feel inadequate, even though we may have lived with it our whole lives. And so, once again, I'm not excusing any of this behavior. The point is that when you train people and train them properly, that they're taking care of persons, who is taking care of whom? A person is taking care of a person. Therefore, you have to train the doctor to be the person the doctor is, not just to see the person the patient is. Well, if you do that, and you start that right off in the beginning, you get very traumatized medical students. And they have a lot of trouble. Things happen, and it scares them. Or things happen, and it makes them very sad. When I was in medical school, nobody gave a shit. People said, you'll be all right. Happens to everybody. I had never found that very comforting. We don't do that at McGill. We actually have a small group of medical students, and each group of 6 medical students has a faculty member, and that faculty member is with them in small meetings several times a year from then until they graduate, and is there for troubles like that. If you support people when they're young and they're having trouble, they're more liable to be open to upsetting things when they're older. When I've done something that wasn't good and I wanted to tell my friends, because you always feel better when you tell somebody, what do they say? They say, don't worry about it, it happens to everybody. That's our phrase, it happens to everybody.
And don't let the lawyers at the hospital know.
Right. Maggie, you had a question?
Yeah, actually, it's a little like that one, and also maybe some actual doctor advice about pain, chronic pain. I've had this multiple herniated discs from arthritis, I guess, that started like maybe right before Christmas, and here it is April. So I've been trying to get better for 4 months. I've been to chiropractor, I've been to, right now I'm doing physical therapy, and I'm doing, instead of the thing, acupuncture. I started acupuncture. Hopefully it's going to start working, but I'm still always in chronic pain. They sent me to a pain clinic. Twice I got a shot that did not help. Like the first time I got a cortisone shot, and then they call you get it on Monday and they call on Friday, and they expect you to say how much better you're feeling, but I'm not feeling better at all. It didn't help. So I go back in 3 weeks. I say, don't give me a shot again because that didn't help. He says, okay, we're going to microwave you. So I think they're going to put me in some kind of machine. Next thing he's giving me a needle, only it's over here. And then he says, see, you can move. But I always could move. It's not a moving thing. I can move. I was a dancer years ago, and I got very good range of motion. But the pain is right here, and moving isn't the problem. It's the pain, the electric, and so I get this pain, and he tells me this is a marvelous shot. I'm going to feel much better. 2 days later, I get a call from one of his assistants, and they say, you feeling better? And I say, no, I'm not feeling better at all. And really? I mean, they act like, well, I must be crazy and making this up because you had 2 shots already and you must be out of pain. But the shots aren't helping. So I don't know, maybe, I'm supposed to go back in 3 weeks, but I'm thinking maybe it's time to cancel that appointment because if they're going to give me another shot that doesn't help, I'd rather not have it. So the 2 questions is, maybe if I go back, I can talk differently in a way that will communicate that I need something else, please, or maybe forget about going there and just do the acupuncture.
Well, before you forget about going there, because you don't know that that's the right, I actually think it's advisable to say, I have to talk now. I'm not here for a shot. I'm here to talk to you. And if they say, I have no time to talk, then you can complain about that. That's what it's talking about. And you say, well, who here can I talk to? And your job is not to tell them, well, what can you do that's really going to help me? Because that just puts you in your job is to say, and this is what happened, and this is what happened, and this is what happened. What do you think I want to do? Now, I don't know who they are, and I really don't want to know, actually. I don't want to know who they are, and I don't want to tell you ought to go see so-and-so, but I don't know if that's right. But I do know that when things aren't going well, you should have that discussion. But what you pointed out was also true. When things aren't going well, you take the blame, like everybody else. When I was in the Army, I had an abscess in my abdomen, and at one point, I was making rounds seeing patients, and I was sick. So I finally got admitted to my own hospital. And when I found out I had a temperature of 104, I was so relieved. That's just like that, right? You know, I want to be a fake or a non-real. So, and that's the side, you know. Being a doctor is a role-related thing, has a social meaning, and being a patient does. But the answer to this is they haven't heard you, and you haven't heard them. And if nobody will talk to you, change doctors.
But there is a
And the
certain...
second part about, do you have any advice or what, how to control, I mean, I think this isn't going right.
No, I'm not going to tell you what you ought to do about your pain, and you want to know why? I don't know a thing about your pain.
Yes, I think that's assuming that that
So-
you wouldn't have that conversation with somebody to figure it out.
So that's what you ought to do. If I were to tell you this is what you ought to do, you would go out of there, you ought to say, he's a jerk. Why? Well, because how can he have an opinion when he doesn't know anything about it? So,
Jesse?
I was thinking, and this conversation was making me think that patient-centered medicine isn't a panacea. We haven't gotten there. I don't know if we can or will. There are a lot of barriers, and the role, certainly patients and people, all people have a role to play. I mean, we're all humans, we're all persons, we're all patients or providers, both in many instances. So my question was, what do you think it will take to bring a person-centered approach more fully into the practice of medicine? It seems like we've made progress. I mean, the timeline that you gave, there was progress there, but clearly we're not there yet by a long shot. Can it be done gradually, or would it, do you think, take a much more radical, transformative change in the paradigm of medicine in the way that we practice? You talked about medical education, and that seems like a possibility where you could make positive changes. However, there's not a lot happening, and there's some things that the school where you teach.
so what the answer, what do I think? I think if you want doctors to do something different, you train them. Doc, remember the guy who landed his plane in the middle of the East River?
Mm-hmm.
What did he say? We just did what we were trained to do. Now, of course, we all know that not everybody does what they're trained to do. But he was trained, wasn't he? Doctors are like that, too. When you train them to do something, and train them, and train them, and train them, you have a chance that they will do it. And as they get better and better at being doctors, the thing they were trained to do will become more and more a part of them and a part of their medicine. Now, the problem is that what do you train doctors to do when you train person-centered medicine? To be person-centered? Well, there's certainly person-centered children. They treat their mother like a mother, not like a person actually, but that's a different matter. But then their mother doesn't treat them like a person either, treats them like a kid. So, but what do we want them to do? Well, at McGill, when we decided how to go about this, which we've been doing now we started thinking about it 6 or 7 years ago, and we've been doing it now for 4 or 5 years, is if you want people to know about persons, you train them in how to listen, how to observe, literally how to look, how to see. You know, that's the hardest thing of all. Osler, who was a super guy, Osler said, observation is the most difficult skill of all. So you think, oh, what's so difficult about that? You're just looking, right? But it isn't that easy, right? See, you know, it's like those pictures you see. There's a wheel missing from a bus, and this is missing, and then they ask you, what's wrong with this picture, and you don't get any of it. Because in your mind's eye, you put that wheel in. Well, that's what everybody does. So we train observation, and we train what we call attentive listening. I actually wrote 2 books about that. We train attentive listening, and we train how to do a different kind of physical, but we're not there yet. But we also train how to write it down. Because if you see something and you can't record it, you won't see it. You have to be able to say what you see. And when do we do this? In the first year. Do the students love it? No. In the beginning they used to say, is this medicine? Is this medicine? Although everything that we had them, all the exercises were about patients, sick people. So we weren't training them how to see by going to an art museum, which is what's done, but I think that's good. Teach somebody to see a patient, show them a patient. Anyway, so now you say to me correctly, but that'll take forever. That's the way it goes, baby. That's the way it goes.
Jan, did you have a question?
I'm on the board here at the Institute, and I'm thrilled to hear this discussion because to me it sounds kind of like this hotbed of postmodernism. And
Not to me,
that's interesting, actually.
but that's a different philosophical issue.
Okay, so I wanted to go back to that, to the philosophical orientation around this, because I heard it in your relation-focused, conversational focused, cultural focused approach to medicine that's broader and bigger, includes science, but extends beyond science. We're sitting in an institute that has experimented a lot with group-centered development and group-centered activity. And I wondered if that's something, if the two of you could talk about your varying perspectives on, can groups get healthier? Can communities get healthier in the same way that you talk about health deriving from the doctor-patient conversation relationship? Can we envision that? Can a group of us help someone get better as we work on here? Say,
Well, that's a different question.
Yes.
That's a different question than the one you asked before.
Okay.
You said before, can groups get better? And now you're saying, here we work on groups, and that's different. But
Okay,
that's whatever way we say it. Let's
Yeah.
pick it. Can groups get better?
and
They
also,
certainly can.
and also, if you could say something about that reaction around the postmodernism, that would be helpful to hear from you.
Well, I'll tell you what I think. I'll tell you so I can make you mad at me right from the start. I think that what suddenly happened is there was no more truth. That's ridiculous. Of course there's truth. Now, what a lot of people whom you would respect say there is no truth. Okay, they say no, and I say yes. I think the God that failed, that made there no more truth was Marxism. But, that's for over there. And once that happened, we couldn't have any truth anymore, or we'd be having that same trouble. But it doesn't really matter, because in the whole conversation about it, interesting things come out. I don't teach in college, so I don't get tied up in faculties, and other people are all tied up in that. But if we go back and say, knowing about community, persons as members of community, is not a postmodern phenomenon. That's been there for some time. But it is certainly different than the emphasis on individuality, which has been part of our culture for about 300, 400 years now. And you can understand how if we've emphasized individuality, it would be hard for us to turn around and look at the other side of individuality, which is relationships and groups. And more people now are doing that and so forth, which is what your institute is the expression, right? So in fact, I think people are more tuned to groups. But let's go back to the question, can a group be made healthy? Well, sure you can make a group healthy. There's a particular group that gets fit like no other group you ever saw in your whole life. They not only get fit, but they get of one mind about some things. And they're called platoons. And the platoon, which is a very interesting group, men fight and die for country, for platoons, for the other people in that platoon. They'll lose their life for their buddies in a platoon. That's, to say it's interesting trivializes it, but it isn't trivial. So, and that's very interesting. And are they healthy? Boy, are they healthy. When I was in the Army and took care of soldiers, you know, a truck would hit them, and somebody would have to sweep them into something, carry them back in pieces, stick them in the hospital bed. In the morning, they'd be playing cards. It was amazing to see how healthy young men get better. But can they also get worse? They did in the Vietnam War, didn't they? Drugs and so forth and so on. Groups getting unhealthy. So is it possible for a group to be healthy and a group to be unhealthy? Yes. Can doctors have something to do with that? Oh, yes. Yes, they can make their patients unhealthy. They can scare them to death, so they're scared all the time. And that's unhealthy. Or they can give them confidence in themselves and so forth, which makes them better. So the group dynamic, that wonderful word, group dynamic is a real thing, isn't it? You know, and the support, look at the thing about breast cancer. When I was in training, there were no support groups because nobody told the truth to anybody. And that was much worse. Now there are support groups. Now they have their limits, but that's for the individual to find. So I'll be right there, I promise. And not too long from now. So the groups, are groups important? Oh, sure they are. Is a supportive family, here is Mrs. So-and-so who has been a failure in everything and anything that ever happened to her, failed marriages, an alcoholic, blah, 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 the whole thing. And she's recently divorced, and she gets, name the disease. And here is so-and-so who's a member of a strong family where everybody is there for her and everything, and she gets the same disease. Which one of them do you think is going to do better? Is that you have to look for fancy psychological things for that? No. Does the groups make a difference? Okay.
Yes. I had a question. My mother had a question. My question was about your earlier comment about Mr. X and him not taking the things that workers like the tour, for example. If you decline to take it, isn't it Mr. X's responsibility, not the doctor's, if something happens to Mr. X?
Yes, I did say that, didn't I? That in fact, why, if we treat him as a person, why can't we treat him as somebody who cannot do something as well as somebody can? Now, on the other hand, look at this. We do that, and something bad. Let's change the drug so it has more immediate effect. Mr. X refuses operation. He refuses to be operated on, and because he refuses to be operated on, he dies. Will I just go in and say, that's the way it goes, he had a chance and he said no? That's not my business. Or would you think,
I think if it truly depended on the person's life, I'd do it. I'd do what was necessary to keep him alive.
there you go. So by your own ideas, and which I might say everybody else pretty much thinks the same thing, you don't mind not doing those things as long as it isn't going to be serious. But once it's serious, you think Mr. X is your responsibility, right? Well, then we get back to groups again. And responsibility. Responsibility is communal. And there are certain people in the population that we think have more responsibility for the health of other people than other people. We call them clinicians or doctors, right?
Yes.
Now you were a cover for your mother's her thing.
My mother was wondering, what do you need to do to find a doctor who not only views you as a patient but as a person and will listen to your views?
I cannot answer the question. What I usually say to people is keep asking your friends and wait till somebody says wonderful things about their doctor.
This is a public policy question, because I think that my experience in the last 25 years of advocating for a more, patient-centered, whatever, human-centered, that patients have been the public, consumers, have been much more active around this than the profession. And that whether it's, support groups to, what are the other, there's a lot of advocacy groups through the internet, that the possibility for consumers to impact on this is profound. And that's what Brockman wrote a whole book, and I went to one of his lectures, and it was packed with, the public who was coming to find out what do you need to ask your doctor to actually get better care. So the consumer training seems to me to be a very important part of this ingredient. I find most of my patients know as much about things as I do, or I can do a little more research, but that to be able to
They
use
have
that.
as much information as you
Yes,
do.
okay.
They don't know anywhere near as much as
That's
you
right.
do.
I mean, they have the same amount of information or access to the information. But what do you think that it would mean in terms of some sort of policy change or advice to Obama, I call it, public policy, that would incorporate this change? Because I think it is a profound change in
Well, I'm
medicine
eager to
and
answer
healthcare.
this because I'm going to say something that they may not like. Remember, when you have bad medicine, it takes a lot of people to make bad medicine. It takes a bad patient population and a bad doctor population. Why? Because you all know what you think you need. You all know what the right thing to do is, and you're all very vocal about it, and besides which, you just looked it up. So you know for sure you're right. Now, I don't mean to make fun of it because often you're wrong. And the thing you're wrongest about is patience. Being patient. Yeah, no, not you, because you've been patient. You see, but why take it personal? I was on your side,
Thinking
remember?
I better be patient to listen.
No, you've been patient. But people can't wait to see if something's going to get better. They can't wait, and they want another CAT scan, and they want to have that. They want another antibiotics. Everybody says, "Well, I know they don't help colds, but I want them anyway because I think." Well, why do you want them anyway? Because you can't not take anything. Mr. Obama and everybody else making good medicine is going to have a hard time, because you're going to fight against the population that wants certain things, just like you'll fight against doctors. Doctors, of course, are now greedy like everybody else. They're so greedy that they're afraid their income is going to be impacted. And so all the things that afflict other people are going to afflict them. But the patient part of it, if you want to be a good patient, do what you're told. And when it doesn't work, that's different. So, but understand that it's not just bad doctors that make bad medicine. It takes a team. What is it? It takes a team to make a whatever. Yes. Yeah, Philip, that's it.
Kitty?
Hi, I'm Kitty McGee, and I'm a registered nurse in psychiatry, and I was kind of afraid to say anything because I said, what if he's one of these doctors that really, doesn't have a good relationship with nurses or something, But, I wanted to sit there and not say anything, but I said I have to say how much I've enjoyed you, and I see the philosopher side, if I'm saying it right, that you're a great philosopher. It comes out in your speech and the things that you say, talking about uncertainty, and you're saying some other things about when the best decision is the one you never make. And just things like this. And I said, I saw the philosopher in you by the things that you were saying. But I wanted to say that I've been in nursing. I've been practice of nursing almost 40 years, and I'm still practicing. And I have had a good relationship with doctors. I don't know of any bad relationships that I've had during the whole time I've been working in nursing, but I do notice that doctors are all different, and I just deal with them according to who they are, and assist with their patients, and we have the one goal in mind in order to, you know, help the patient in the way that, you know, is what's best for the patient, and listen to the patient, you know. I was trained like in the newer school of nursing, and although I've been in nursing for a long time, it's still like the newer school of nursing as opposed to the old school of nursing. But I'd like to say also that one thing that really impacts on the doctors within the hospital today is that they want numbers. And it's very hard for the doctors to really take the time to listen to patients in a hospital setting, especially in a clinic, because you got all these patients sitting out there, and you know it's about numbers with the hospital. If the doctor takes up too much time with one patient, you know, he gets ecstatic from the administrators. So I think that, and the last thing I want to say is that I see from working in medicine and psychiatry, I've seen that it's come a long ways toward what you're talking in terms of patient-centered medicine. I see that it's really have come a long ways toward that end. Now, I actually know a lot of doctors who are actually in their own practice who are taking up a lot of time with patients who are actually doing the things that you were talking about. And I would say that I don't think it would be long before it's really, you know, the way that probably as you expected as a doctor, you know, and as a very, I'd say, very prestigious doctor and a learned doctor, try to find the best word for what.
You're doing all right, I want to tell you.
For you to make the judgment, for it to be to your expectation.
A month ago, to the American Academy of Hospice, now it's called Hospice and Palliative Medicine, there were 2,000. 2,000. Why? Well, because it's gratifying medicine. And because it is for them, they tell their friends, So those changes that you're talking about do happen faster than one would predict, but slower than because I always want it to be tomorrow. And so you're absolutely right that when the tide changes, and incidentally, the political change in this country is part of that change. So I do think it'll happen sooner than it would have otherwise, but not very fast. Now, the numbers. One more thing, just about numbers. You know, you go to make rounds teach in a modern hospital. The patients are over there in their rooms. God forbid we should disturb them by going to see them. What we do is we crowd around the computer. And the computer has the numbers. It has yesterday's numbers, the day before numbers, and today's numbers. Doesn't have tomorrow's yet, but and it's got the x-rays too, because they're on the computer now, everything. So everybody sits there and they have their opinions about the numbers and the x-rays, and they don't go see the patient.
That's another number.
And that's not just me talking. That's a common problem. And they don't examine patients because, after all, what's the point of listening to somebody's heart when you can get an echocardiogram, right? And that's much better. Anyway, the trouble is if you don't do it every day, that's why I never examine anybody anymore. If you don't do it every day, you're no good at it. And of course, if you think the echocardiogram is better, then you're not going to do it every day. But on the other hand, echocardiograms are not done every day. So you don't get a chance to listen every single day. And you don't get a chance to learn, never mind the patient, the hell of the patient, to learn something by examining somebody every day and realizing what normal really sounds like and how it varies from day to day. And you don't get a chance to put your hands on that patient, which the patient dearly loves. And you don't get a chance to learn more about a person, which you learn by touching them, and so forth and so on and so on. So, when we crowded around the numbers, it isn't just the numbers that hold us. We begin to be held by our lack of skills and so forth and so on. That's why medicine cycles bad and also cycles back up.
We have time for a couple more questions. You're over here, and then
this whole conversation has seemed to me somewhat more centered on the philosophy of doctors toward patients than the other way around. And I'd like to know if it's really gratifying to hear that care of the dying is so gratifying to clinicians that they're all racing to do that, but as somebody who's not scheduled to die.
Oh, yes, you are. You just don't know when.
Not tonight. Yes, hopefully not tonight or not under the care of any of you. But how does a patient make themselves as gratifying as these soon-to-be dead people, and from a philosophical point of view?
Yeah, that's a good question.
Well, that is it. How do you get the doctors to look at you as a gratifying patient? I had a patient one time who had a chronic and recurring, very acute problem, put her in the hospital all the time. Boy, she learned in one hospitalization how to manage those nurses and doctors. She was wonderful at that. And how did she do it? She was very appreciative of everything, and she told them how good they were and all that. And she had them eating out of her palm in no time at all. She really ran them. It was wonderful to behold. But, and that's real. You can be a nasty patient, and nobody loves that either, but who gives a damn if that's what you want to be, and you'll be that. But more important to me, how about the dying person? Is it as gratifying to the dying person to be the dying person is the most gratifying thing as it is to be the patient? Well, obviously, most people didn't sign up for that, although they didn't know, but they really did. But anyway, the thing about it is, you know, but you know, if you're in an environment of good care, it feels better than an environment of poor care. And it makes a patient, you know, you can be better even if you're about to die tomorrow. You could be healed if you're going to be dead in a week. What does healed mean? You can do the things, you can function in order to meet your goals and purposes to go with where you are then, which may be simply being able to say I love you to somebody, and you have a lot of trouble with doing that otherwise, or being able to say, I know this is going to be hard, but I want my sister to come and see me. Whereas before that you couldn't say that, because that bitch, the way she was when you were a kid 50 years ago, is still hanging over the bed, but you can be and so forth. So you can be healed in that environment also. And you can be forthcoming in that environment. Remember, there are two people there. There's the clinician, nurse, or doctor, whatever, and the patient. And you can have a gratifying exchange. You can think with reason that you really love that person for the care you got. You can think, I really love you. And people say, oh, how can you really? Yes, you can. A dying person of all people ought to know that. So you see, it's one of those things again, is that it's a mutual relationship that happens, but the environment is also very, very important. Now, I spent some time in a neurosurgical intensive care unit about this time last year, and I didn't think it was fun, but I know what to say to them, so they'll be good boys and girls, and to do what I want them to do. I couldn't get them to let me sleep, but you can fight with the whole thing. Right? If you fight, you'll lose, because it's their world and their rules. What if you're compliant to the degree that you can, and pee on schedule and do all those nice things? Then life goes better for you. What does this say? Only that it's always people. two people together. We want them to be skilled, and we want you to be appreciated. And if you are, you'll be an appreciator. You'll appreciate them. And that will return the reward in the other direction. Let a doctor work in a place where there are no such rewards. It's very unsatisfying. So I guess.
Well, I was thinking that sometimes my most gratifying interactions with patients are not always when I'm at my grumpiest, and I might be speaking, and people say, "Hey, what's going on?" Or the equivalent of that, or "You're not being attentive to me," or something to call attention to that, and it literally can transform the conversation, because patients aren't supposed to say that, and it's a new performance, we would call it here at the Eastside. But I think that patients can learn new performances, which can be very impactful. What you're complaining about, and I know people say, well, they don't listen anyway. But I think trying new performances on both sides can make a difference. And
you're going to make a difference because you're going to say, I really need your help. I'm really not better, and I really need your help. I need you to talk to me so I understand better. Not so I'm blaming you, but so I understand better.
Yeah. I mean, it breaks the autopilot.
It'll make a difference when you do that. You're not going to go in angry, which you may be. You're going to go in as though you really did want to talk.